Good afternoon, everybody. As the slide says, I'm going to just talk about what OHCAR tells us about CFR at the minute. For anybody who doesn't know at this stage, I think you've heard a bit about OHCAR already this afternoon and this morning. The reason that we have a National Out-of-Hospital Cardiac Arrest Register was because of the report of the Task Force on Sudden Cardiac Death, and that had a specific recommendation that FEC should build a work already underway to establish a register of cardiac arrest. And FEC, as usual, duly did that, and we had the inaugural meeting of the OHCAR steering group in June 2007, and from then on we started working at getting national coverage so that we would be able to report on as many cardiac arrests where resuscitation was attempted as possible in the country, and we achieved national coverage in 2012. So from 2012, again, I think you might have seen this slide, this is a structure of OHCAR. It's hosted within the Department of Public Health Medicine and the HSE. It's jointly funded by the National Ambulance Service and FEC, and it's supported academically and administratively by NUA Galway. It's a structure that works pretty well for us. And the purpose of OHCAR, the purpose is to facilitate improved survival from out-of-hospital cardiac arrest. Data itself never solved anything, but as some of the other speakers have said, if we don't know what we're doing, how can we improve on it? And the way that we hope that information will help us to improve survival is that we need to establish what the percentage cardiac arrest survival is, know what the factors are that contribute to survival, and know what we should do differently to help to improve survival. And we need to get the feedback to the people who are on the ground, helping people who suffer this. The case definition Cathal mentioned is all patients who suffer a witnessed or unwitnessed out-of-hospital cardiac arrest that's confirmed and attended by emergency services and resuscitation attempted. So it's not all cardiac arrests, it's cardiac arrests where there's resuscitation attempted. To keep things as simple as possible, we say to those that are involved in cardiac arrest, if resuscitation is attempted by anyone at any stage, you probably have an OHCAR. So don't spend too much time wondering, should I submit this to OHCAR or not? You probably should. These are our main data sources: ambulance control, the patient care report that the ambulance services use, and the cardiac first responder reports that you yourself use. If the patient's brought to hospital, we get data from the receiving hospital. As I say, this is the back of the ambulance PCR, and it's specifically designed for OHCAR. And even in the event that we don't get a cardiac first responder report, at least this form allows the ambulance practitioners to record that a CFR was actually present. And of course, this is the important form from a CFR point of view, and very valuable information for OHCAR to get. So this is just, I'm going to give you a little bit from our first year of national data. Cathal had this slide also. And the reason that I'm showing this slide is that we've 1,800 cases in 1 year. About half of them were in urban areas, and that means about 1,000 cases were spread across the rest of the country. And the problem with looking at data like this is that we have nearly 1,800 cases where there was different people in different situations with different responses. If we look at this data for 2013, it's very difficult for us to work out how can we make things better. So for that reason, we have a group. We look at a subgroup of the 1,800 patients, and we call it the OHCAR comparator subset. And this is adults who had a cardiac arrest of presumed cardiac cause, where there was a bystander witnessed and where the patient was in a shockable rhythm at the time of first rhythm analysis. And the reason we look at this group is, this is the subgroup of patients who are most likely to survive if the chain of survival is enacted properly. So at the minute, or for 2012, this subgroup made up about 15% of all cardiac arrests. So success would be if we could make that group bigger, because the more of these patients, the more patients we have in this group, the more chance we have of helping people to survive. And also, of course, we want more patients in this group to survive. So I certainly don't need to preach about the chain of survival to this audience, but I think from the point of view of CFR, it's the latter 3 points that are most important. Now again, this is our slide of our 1,800 patients again. And I put up this slide and just to demonstrate or describe that the green and the yellow splodges are 5 and 8 minute travel times from the ambulance stations in the country. So I think with the best will in the world, without CFR involvement, we're never going to get to all cardiac arrest within 5 to 8 minutes. This is for the 268 patients, and you could say that's fabulous, bystander CPR in 78% of cases. But it also means that in the subgroup of patients who were most likely to survive, more than 1 in 5 of them didn't get bystander CPR. So if we could decrease the size of that red piece of the pie, we could have substantially more survivors. I think this is encouraging. It's like nearly the opposite slide. But it means that in more than 1 in 5 cases, there was a shock delivered before the ambulance service arrived. And that translates into more than 1 in 5 patients in this group surviving. But from a CFR point of view, the most important thing is that nearly 1/3 of those survivors had defibrillation attempted before ambulance service arrival. So if we can increase the number of patients who are getting a shock before the ambulance service arrives, you can just imagine what kind of impact that would have on survival. So does OHCAR suggest that CFR involvement improves out-of-hospital cardiac arrest outcome? I think it's pretty obvious that it does. But how well does OHCAR capture CFR contribution? That bit I'm not so sure about. And I think that there is opportunities for us to get better at including CFR data in OHCAR. In terms of quantity, how many of the cases we're capturing at the minute? Are we getting all CFR cardiac arrest events? Probably not. I think particularly I would be aware of the big sporting and entertainment events that are managed by the non-statutory ambulance services. If you transport a patient to hospital, we never hear about that patient. And when it comes to quality, at the minute we do rely heavily on the ambulance service to get those CFR reports to us. And when it comes to quality, there's no doubt that if the best source of the information is the person who was at the scene. And we have an example of that working well. We actually get our data directly from the Dublin Airport Authority, and the quality of information that we get on arrests that occur in the airport are second to none, so it certainly works. So I think at the minute what we have is we have a sketch of the national picture. We've a good idea of what's going on nationally, but what we really want is a real portrait of out-of-hospital cardiac arrest in Ireland, because the more information we have, the knowledge is power at the end of the day. So the more information and the better quality information we have, the better.